this special feeling that makes our hearts go boom. Holding hands with strangers, stopping all their tears, safeguarding their futures, banishing their fears. Why do we work so tirelessly and go that extra mile? 'Cause we love to see people smile. Yes, we love to see when they smile. Better education can give a child a start. A safe and caring shelter can warm an orphan's heart. A tree can make a difference, bring water to a well. A dam can help a village survive the driest spell. And this is why we work so tirelessly and go that extra mile. 'Cause we love to see people smile. Yes, we love to see when they smile. 'Cause we love to see people smile. Yes, we love to see when they smile. 'Cause we love to see people smile. Yes, we love to see when they smile. More precious than a gold mine, much brighter than the moon. There's a special feeling that makes our hearts go boom. Holding hands with strangers, stopping all their tears, safeguarding their futures, banishing their fears. Why do we work so tirelessly and go that extra mile? 'Cause we love to see people smile. Yes, we love to see when they smile. Better education can give a child a start. A safe and caring shelter can warm an orphan's heart. A tree can make a difference, bring water to a well. A dam can help a village survive the driest spell. And this is why we work so tirelessly and go that extra mile. 'Cause we love to see people smile. Yes, we love to see when they smile. 'Cause we love to see people smile. Yes, we love to see when they smile. 'Cause we love to see people smile. Yes, we love to see when they smile.
Good morning. I hope you can all hear me. Good morning and Happy New Year. We are happy to have you this morning. You join us. We missed you while you were away. Welcome to APA Insurance, the home of happiness. We love to make people smile. We love to make people happy. Once again, we are humbled to have you this morning. Thank you so much for taking time to join us. Na karibu sana. With me on the ground, I have my colleague, Mr. Justus Munene, and I have other special guests who will be joining us in a minute, and I will introduce them as we go. On behalf of the APA family, we are humbled to have you this morning. Karibuni sana. I would like to take this special opportunity to invite one of our own Chief of Staff, Madam Irene Mutonyi, just to take us through a new product that APA has. It's called the Shield. I don't want to expound on that. I'm also excited to know what it's all about. So, Madam Irene Mutonyi, I don't know if you can hear me.
Yes, I can hear you. Give me one quick second and I will be up and running with the PowerPoint. Thank you,
Karibu sana,
Zainab.
madam. You're welcome.
Okay. Okay, I'm hoping that you can see that screen with my with the presentation.
Yes, we can see it.
Okay, awesome. Okay, good morning, everybody. This is Irene Mutonyi. As Zainab said, I'm the Chief of Staff here at APA. We are very, very glad to have you here. And I'll just take a couple of minutes just to introduce who we are and even just give a little bit of background about APA Shield, which you may or may not have heard about. Just one second, I'll put it on presentation mode. Okay. So APA is a group of companies that is focused on meeting all your financial and risks needs offering risk solutions to both corporates and individuals. We have 4 arms. We have APA Insurance, which is what many of us on this call may know. We provide general and health insurance. We have APA Life, which takes care of the life insurance aspects of the business. And we have Apollo Asset Management, which is focused on exclusively meeting the needs of the investment needs of both individuals and corporates. So in this world of insurance, there are so many offers out there. Why are we talking? Why do we say come to the Apollo Group? We are offering a stable business, and I'll not go into all the details of this, but what I want to assure you is we are focused on maintaining our position as a trusted and reliable insurer who will meet your insurance needs in whatever capacity, whether you're an individual, a corporate, an SME, or a retail owner. I would love to emphasize that we are working hard on digital adoption so that we work towards meeting your needs conveniently. We work with intermediaries as well. We have intermediaries all nationwide, and they all are there to listen to your needs and provide solutions as needed. So you've heard about APA Shield, or perhaps not. APA Shield is a program that we introduced here at APA we recognize women are an important aspect of our day-to-day. We understand women also have distinct needs, and we've created a platform that caters for those needs where we can engage with you, and I'll speak about that in just a minute. And also we want to partner with you to create meaningful solutions to provide for your well-being at every stage of life. How are we doing this? We have 3 pillars. We are looking at your protection, we're looking at your health and wellness, and we're looking at wealth as well. And what we are gearing towards is making sure that at every stage of your life, whether you're a professional woman, a stay-at-home mom, a mama mboga, or as an SME owner, any stage of your life, we have the health, the wellness, the wealth, and protection needs catered for you. And I'll encourage each of us to go into our website. We have a lot of detail about what is entailed in each of these buckets. But today we are actually focusing on the health aspect. And the topic of our discussion is on cervical cancer. And we all, there have been statistics that show cancer has been a lead cause of death here in Kenya, and particularly cervical and breast cancer. And we know also that these are preventable if caught at the early stages. So that's our focus for today. And I would love to introduce one of our medical team members, Sheila, to just take us through what Femina Plus is all about. It's a great package. And even as she goes in, one of the distinct factors we want to emphasize here is that it's an insurance solution for those who are actually well, but so that we can take preventative measures in ensuring that you are vaccinated as needed or screened, and the breast cancer is caught early at the time it's needed. So I don't want to take too much time because we want to hear the speaker as well. So I'll hand it over to Sheila and she can take us through the aspects of Femina Plus.
Thank you very much, Irene.
Sheila, should I keep the presentation or?
Yes, please.
Okay, sure.
Thank you very much, Irene, for taking us through the APA Shield, and good morning to everybody on the webinar this morning. My name is Sheila Gishohe. I head the client retention team here at APA in the health business, and we're here to take you through the APA Femina Plus, which is one of the products under the APA Shield program. Now, as we've said today, we are having the webinar today on cervical cancer, and APA Femina Plus is one of the products that can support any of our members if they were diagnosed with cervical cancer. Now, the APA Femina Plus is a wellness product that has a critical illness benefit built into it. Women's cancers are among the leading causes of critical illness and death in Kenya. Early diagnosis, regular screenings allows members to engage and have better treatment, and it actually improves the chances of survival. HPV vaccinations reduce the risk of cervical cancer by more than 90%. Now, we encourage women to have their medical checkups done regularly. All our medical covers include an element of screening and medical checkups annually. So the product that we've developed as APA Femina Plus actually doesn't only pay out an insurance benefit, but it covers the wellness and screening elements to make sure that any member who's on our policy and purchases the APA Femina Plus is able to actually have their screening done in good time. Any issues that are caught are actually treated on time and allows better survival, better chances of survival. So what does the Femina Plus offer? As I've said, this is a wellness product that has an element of critical illness. Now, critical illness is a benefit that is given in terms of a lump sum payout to a member who is diagnosed with a condition that is covered on this particular product. Now, this product allows you access to screenings. As we've said, it's mainly a wellness product, encouraging ladies to get their screenings done so that diagnosis is done early. So the benefit of this policy, you have access to screenings. We have screening for breast and cervical cancer, and we also have HPV vaccinations, which reduce the risk of cervical cancer. In case a member is diagnosed with either breast, cervical, and ovarian cancer, then the policy will pay out a lump sum benefit based on the stage of the cancer. So in this product, we have 3 options that a member can select, either the silver, gold, or platinum options. And these options all are broken down into stage 1, 2, 3, and 4. Now, these are generally the stages of cancer based on the diagnosis that the member has. And this will be determined at the time of diagnosis. The doctors will be able to advise what stage the cancer has been diagnosed at. And based on that stage, for example, if you had selected a gold option and you were diagnosed at stage 2, then in this case, we would pay out a lump sum amount of 1.5 million under the gold option for stage 2. To enable you use the funds to manage the expenses for your treatment and any other expenses that you have related to either the cancer or personal expenses if you have to be away from work or to travel for treatment. Now, the screening and vaccination costs are also covered, as I said, within the limits that you have. So we've partnered with service providers on our APA provider panel, and they will be able to have the screening done so that we diagnose them any conditions early. Now, in terms of the premiums, based on the benefits I've indicated, the premium structure, we have the 3 options, again, silver, gold, and platinum, indicated there as option 1, 2, and 3. The premiums can either be paid monthly or annually. Now, the annual premiums are for individual members who would want to purchase the policies for themselves. The monthly premiums are payable for members who are under a corporate account, where we can coordinate with the employers to deduct the members and remit the funds to APA. So the annual option for silver, the premium is 6,000 shillings with additional taxes included. 12,000 shillings for the gold option and 15,000 shillings for the platinum option. So the premium is payable annually either by the employer or the individual members. We will be engaging all the employers just to take them through the product and advise them on how to purchase for their members. We have all the information, the brochure, application forms are on our website, www.apainsurance.org. We'll also put that in the chat to make it easier for you to access the APA Femina Plus details on our website. And we look forward to, thank you very much. There is the email. This email will come directly to the team dealing with our APA Femina Plus product. You can either email Femina Plus at apainsurance.org or call 0709 912 888. And you can access any of our social media on Twitter, Facebook, Instagram, and LinkedIn. And also, as I said, our website where you get more information on this product and any other products that we provide. Thank you very much. I will hand you back to Zainab. Feel free to put any queries. Sorry, feel free to put any queries on the chat and we will respond.
Thank you so much, Sheila. Thank you for taking us through the Femina plan. There you have it. It's a beautiful product. We'd love all women to have that because you never know when we need it. I don't want to waste so much time. We are grateful to Madam Irene and Madam Sheila. Sheila is in the medical department. She's our head of retention. Therefore, you are all in good hands. So without much ado, I would want to welcome the main guest of today, Madam Maureen. That is Dr. Maureen Owiti. Dr. Maureen Owiti is sorry about that.
Lost you?
Yeah, I've had sorry about that. And Maureen is an obstetric gynecologist with vast experience in the field and has great devotion to women and their needs, especially in their reproductive health. And that is why today she took her time to come in and take us through the cervical cancer because it's one of her passions. She actually completed her school in Russia and joined the University of Nairobi for specialization. Since then, she's worked in several county hospitals, and currently she is a lecturer at the School of Gynecology at the Kenyatta University. And she works with public sectors and also works with public sectors. She's currently based at the Kenyatta National Hospital. She also runs Gynecare alongside her partner, Dr. Jane Mashira, and together they do a wonderful job. That is how we are humbled to have her this morning. We felt it's good we have one of our own take us through the experiences so that we can learn. So without much ado, I want to take this opportunity to welcome you, Dr. Maureen Owiti. Can you hear me?
Thank you, Zainab. I was wondering who you're talking about. Anyway, thank you so much. Morning, everyone. And I'd really like to thank you, Zainab, for inviting me. I'm very humbled to be given this opportunity. I'd also like to thank Irene Mutoni, the Chief of Staff, and the entire APA team for giving this opportunity. APA has been one of our partners at Gynecare, and I think from an insurance perspective, from us doctors, it's one of the more responsive local insurance companies. And I'm very, very happy, actually. I'm very happy to learn about the APA Femina Plus. Even if you look at the cost and the benefits they want to pay out, I think it's something that is it's timely. It's very, very timely. And I think the insurance industry is actually learning the benefit of prevention vis-a-vis treating, because for a long time, you find things like vaccination and screening. Most people have to pay something extra. It's not part of their routine insurance. So I'm also hoping that you could be able to incorporate this into the regular insurances that you're giving the people who you provide insurance to. But this looks like a fantastic product. I think I'll also look into it myself. So just to everybody, we've just finished, but today is the 2nd of February. So Cervical Cancer Month was January. So I was just reminding us. So, but I think this is the time that was available. And on Sunday, which will be the 4th of February, is World Cancer Day. So today is actually smack right in between days when we remember cancer. And for me, I had actually wanted to put up a picture of one of our very own, that was Catherine Kasavuli. I think we all know that we lost Catherine Kasavuli last year due to cancer of the cervix. And maybe we just take 1 minute, a moment's silence, to remember all people who have gone to be the Lord from cancer of the cervix. Okay, thank you. So why I'd want us to remember those who have gone is that for me as a healthcare provider, I think one of the saddest things to ever see is someone suffering from cancer of the cervix, because we have known for a very, very long time that if there's any cancer that can be prevented, 100% it's called cervical cancer. You can't say this for breast cancer. You can't say this for prostate cancer, because if you find something like breast cancer, you can treat it, but you cannot prevent it. And the same goes for prostate. But cervical cancer is at a very opportune place whereby it can actually be prevented. And thank you, Sheila, for laying the groundwork for what I was about to present. So let me share my screen so that we can start the presentation. So just some feedback if you're able to see my screen.
Yeah, yes, Dr. we can see it.
Okay, thank you very much. So what is cancer of the cervix? And it's a type of cancer that occurs in the cells of the cervix, in the lower part of the uterus. And the cervix is the lower part of the uterus that connects the uterus and the vagina. And we have known for a very long time that it's actually a sexually transmitted disease, and it's caused by what is known as the human papilloma virus in more than 99% of cases. So if we were to look at the anatomy of the uterus, of the reproductive tract, sorry, I'm not seeing, sorry, 1 minute. Just looking for the pointer. So if you can see the laser, this area is what we call the cervix. It's connected to the uterine body, our fallopian tubes, ovaries, and vagina, just remembering the anatomy of the pelvic organs. So it's the 4th most common cancer in women, and we have an estimated 604,000 new cases every year, and about half of those cases will die. And that is statistics from World Health Organization in 2020. And it follows breast cancer in terms of new cases diagnosed will be about 2.26 million. Colorectal cancer, and these are the statistics for women, not for all population. 0.86 million for colorectal cancer, and lung cancer, 0.77. And unfortunately, in as much as the incidence is high, it is actually the leading cause of cancer-related death in women in Eastern, Western, Middle, and Southern Africa, technically the whole of Africa. I've mentioned that it's caused by the human papilloma virus, and we have over 100 documented genotypes, and 40 of which are going to infect the anogenital tract, and between 12 and 14 of them are high-risk genotypes. And I think the ones that we know most commonly is HPV 16 and 18, which are responsible for more than 70% of cancer, cervical cancer. We have other HPV like 11 and 6, which will cause genital warts, which are not exactly something that somebody would want, but at least from warts, you are not going to die because of warts, but you can die because of cervical cancer. More than 80% of women will become infected with HPV at some point of their life. But why some people develop cancers and others do not, we do not know. And but the beauty is, for majority of people, the infection of HPV clears naturally. So this is just a diagram of what happens, that when a woman is exposed to the virus, it is going to infect the epithelium, that is the lining of the vagina and the cervix, and it's going to start replicating inside the cells. And after that, if your body, your immunity is not strong enough, you find that, which is in about 10% of cases, over 10 to 30 years, about 0.8% are actually going to develop cancer. So that was my pointer. So the virus enters the cells. It's several weeks later, it starts replicating. Then 90% are going to heal. And after 10 to 20 years, you're going to have some people developing cervical cancer. And I've mentioned already that it's primarily spread through sexual intercourse. But unlike HIV and hepatitis, with HIV and hepatitis, condom use has proven to be very, very effective in terms of prevention. Unfortunately for HPV, it's a very, it's like COVID, it spreads very easily and all over the space. So you don't even need sexual contact to be infected with HPV. So you find even lesbian couples who may not necessarily have penetrative intercourse, and even going for things like waxing and all sorts of things would predispose you, and sharing intimate items like your towels and what you're using to clean yourself would predispose you to getting human papillomavirus. Are there risk factors to getting human papillomavirus? So aside from being in close proximity to some and using things for someone who had human papillomavirus, people who have HIV/AIDS, obviously because the immunity is lower, things like smoking, use of birth controls for a long period, having had multiple births, more than 3 to 4 times, having several sexual partners, and if you have early onset of sexual activity or early marriages, and obviously a family history of cervical cancer in the family, but noting it is a sexually transmitted infection, it is not a hereditary infection like breast cancer. So how fast does it spread? From, I think, the chart that I showed, which showed that from infection of the human papillomavirus, it's going to take between 10 and 30 years before you develop overt cancer. So that is giving us opportunity for prevention, early detection, and even treatment. And with the help of everybody, whether it's the international bodies like World Health Organization, the UN, the stakeholders like the insurance companies, APA, and us ourselves, the clients and doctors, we can actually eliminate cervical cancer. So because the topic was on cervical cancer, we'll start with what are the symptoms. So most women who have overt cancer the first thing they're going to complain of is bleeding. And this bleeding is very interesting. It's outside of their periods and normally will occur after some contact. So normally it's sexual contact. So you find a married woman, she has intercourse with her husband, and after this, she starts spotting or bleeding. Some present with a very foul-smelling vaginal discharge. And in very severe cases, they can have actually pain during intercourse. And in postmenopausal women, it's a possibility for having bleeding, and any form of bleeding in woman who deems herself to be menopausal. So menopause is a retrospective diagnosis. You need to have not had your periods for 1 year and you're not using any form of hormonal treatment, therapy, or contraception, then we diagnose to you to be in menopause at that point in time. So any bleeding after you consider yourself to be in menopause is not normal, and someone should immediately go to the doctor to get checked. And if you have unexplained persistent pelvic or chronic back pain. Other than bleeding after intercourse, some people also find after going for a long call or a short call, they also just bleed spontaneously. So this is just a diagram telling us the warning signs of cervical cancer. So you have the discharge, the bleeding, heavy cycles, discomfort while urinating. There are those who lose bladder control, so they have incontinence of urine, pain during intercourse. When you're tired, they tend to bleed, so you get anemia and you feel tired all the time. You have pelvic pain, unexplained weight loss, and with majority of cancers, the leg pain could be because of clots. Cancers tend to predispose people to get clots, blood clots in the veins. So we said prevention is always better than cure. And we have different types of prevention based on the lifespan of a woman. So in primary prevention, this is prior to exposure to the human papillomavirus. You're most likely going to get exposure to human papillomavirus when you start sexual activity. So the best age group to give any preventative measures would be in the age group 9 to 14, where we're going to do our primary prevention. And this is where the vaccine comes in. And vaccine can be given to both girls and boys. And you're also going to, in terms of prevention, primary prevention, is explain to people to avoid early onset of sexual activity, and to avoid having multiple sexual partners, don't smoke, and use of condoms. So in as much as you said that condoms don't prevent, they still will assist. And it has also been proven that male circumcision is beneficial for preventing transmission of STIs. So that would also be something that would be under our primary prevention strategies. Now, in secondary prevention, this is when somebody is already exposed to the virus, that's the human papillomavirus. So it means that these are for women who are aged 30 years and above, and or any woman who has been sexually active. So you are going to do any form of screening for cervical cancer. I think I have a slide on that. And then we have tertiary prevention. So in tertiary prevention, or long and short, that is treatment. When we have done diagnosis and seen that there is actually cancer, you're going to treat, and the treatment is from surgery to radiotherapy, chemotherapy, and obviously palliative care. So we've said that it can be prevented, and in primary prevention, we're talking about the vaccine, and no woman should die because of cervical cancer. And I think we've mentioned all of that. And it's understanding that the HPV vaccine has potential to prevent more than 90% of cases attributed to the human papillomavirus. And this vaccine was first introduced in 2006, and it prevents HPV cancers and genital warts. This is an image of when we rolled out the vaccine in Kenya. So in Kenya, the vaccine is available at no cost to young girls aged between 10 and 13. When they initially rolled out, it was girls aged 10 years. But I think due to the poor uptake, they widened the scope for 10 to 13. And we are using the bivalent vaccine, and the girls are getting 2 doses. And this was just a picture of when His Excellency, our former President Uhuru Kenyatta, was launching the vaccine. For me as a healthcare provider and somebody who works also in the public health space, it's very saddening that we are actually throwing out vaccine because the uptake of the vaccine has been very, very low. Whether our strategy on communication to parents, because it's parents who need to make that decision and send their daughters for the vaccine. I'm very proud to say that I took my daughter and a number of her friends to benefit from the free vaccine, and we got it at Kenyatta National Hospital, and it's still available. And I would really advise anyone who has children, especially girls, because from our vaccine schedule, we are vaccinating the girls, to please take advantage of this. And the reason for this is that we know that it's a common virus that affects both men and women. We know the vaccine works and it prevents cancer. And we all know that prevention is always cooler than health. In terms of facts, we have in Scotland, there was a study done, and it was invasive cervical cancer incidence following bivalent human papillomavirus vaccination, a population-based observational study of age at immunization, dose, and deprivation. They were comparing those who received the vaccine and those who did not receive the vaccine, because I think it's voluntary whether to get the vaccine or not. So in that study, what they did was that they got women who were born between 1st of January 1988 and 5th of June 1996 from what they call the Scottish Cervical Cancer Screening System. And that was in July 2020. So remember, the vaccine was introduced in 2006 and linked to their cancer registry and the immunization and deprivation data. So they found, they measured the incidence of invasive cervical cancer per 100,000 person years, and vaccine effectiveness was correlated with the vaccine status, as in have they gotten the vaccine, age at vaccination, and whether, and those who did not get the vaccine. And from that, because this is a population-based study, so these are huge numbers you have, you find that they were using, in Scotland, they used the bivalent vaccine. It's understanding that vaccines come in various forms. And we have a bivalent, which was the first vaccine introduced, which is against 2 strains. We have a quadrivalent, which has it's against 4 strains, and a nonavalent, which has against 9 strains of human papillomavirus. But for this particular study, they were just using the bivalent vaccine, and it prevents the development of invasive cervical cancer, and that even 1 or 2 doses a month apart confer benefit, even if given to girls between the age of 12 and 13. At older ages, they feel that you require the 3 doses for statistically. So in that study, the girls who received the vaccine, none of them to date have gotten cervical cancer. So this is pure proof that the vaccine works and we should go for the vaccine. We talked about, so if your primary strategy has not worked, so we have, like I've mentioned, in the country, the vaccine is available, but for whatever reason, a lot of girls are still not accessing. So we're going to have those who have received the vaccine. So I'm quite happy with that data. So I feel I have protected my daughter from a possibility of developing cervical cancer, and her friends. So for those who are less fortunate and did not access the vaccine, we find that once they have started sexual activity, we are going to do screening. And screening is done, and we're also going to encourage, they can still use the vaccine. So it's not to say that because you've been sexually active and exposed to human papillomavirus, that you cannot use the vaccine. We can still vaccinate women up to age of 45, but we're going to still advocate for regular screening. And also remember that having received the vaccine does not exempt you from screening for cervical cancer. So they still have to do their pap smears or what we call the HPV testing. And I think I'll explain the other forms of screening. And we're still going to advocate for avoidance of early sexual debut or onset of sexual activity, for condom use, to avoid multiple sexual partners, and to seek treatment for STIs promptly if one is infected. So our screening strategies will be the proverbial pap smear. I think most people are aware about a pap smear. In the public healthcare system, we screen using what is called VIA-VILI. I'll explain what that is. And you can also do the human papilloma virus DNA testing. So the pap smear, it's an exam that doctors use to test for cervical cancer. And what it does is that we collect cells, we put on a slide, and they are able to see from those cells if they have any changes that are consistent with pre-cancerous. So on a pap smear, we are not looking for cancer. We are looking for changes that occur before cancer. Remember, we said that the virus is going to infect the cells and it's going to replicate and it's going to cause changes before you actually get the actual cancer. So we're looking for you at that stage before you develop the advert cancer. And right now, the screening schedule is at least every 3 years from the age of 21 to 65. And you can actually combine HPV testing with a PAP. And so if you have a woman who's less than 20, and especially in countries where it's universal to get vaccinated, you don't need to do a screening. But in women 21 to 29, you're going to do a PAP every 3 years, but you don't need to do the test for the HPV. In women 30 to 65, you do the PAP and you can add HPV testing. And above 66, if they have always been normal, you don't need to screen anymore. After that. So this is just how we are able to do the pap smear. So that's the speculum, which I think most of us don't like. But I make a joke when I'm seeing my patients that I call myself a pap smear whisperer, because I believe I'm very gentle. And I think more than 80% after the pap smear will agree with that. Anyone who's been fortunate to have a pap smear from myself, who's in the audience, I'm sure can attest to the same. All I can tell women is that it's not painful. It's a minor discomfort. And if you cooperate with whoever is doing the test for you, it will just be some minor discomfort during the procedure. So in VIA-VILI, we are going to apply acetic acid, which is our common vinegar, and some iodine dye that we call Lugol's iodine, to see if there are any changes on the cervix. So with the vinegar, when we apply the vinegar on the cervix, the areas that have those precancerous changes will turn white. And when we apply the iodine, it's going to turn brown. So here it's a normal finding whereby you can't see the diagram to the left of the screen. You cannot see any white lesions. I think this is a reflection of light. And the iodine, the cervix has taken up all the iodine. Everywhere is a nice mahogany, deep brown color. Whereas if you have a patient who has a cervical cancer, you're going to see these white plaques, this area. This is the white plaques when you put the iodine, and the same lesion, when you put the vinegar, and the same lesion when you put the iodine, you get that it doesn't take up the iodine and remain as a saffron or yellow lesions. The last is to do a HPV testing. So this is available in the country, whereby if you really feel you don't want to see us doctors, you can collect a sample by yourself and have it taken to the lab to be tested for HPV. If we find you have HPV 16 and 18, that is, if it's positive for HPV 16 and 18, you will need to come in for further tests. At that point in time, yeah, your doctor is going to take over what is going to happen. So for any screen positive, so whether it's the pap smear, whether it's the VI-Vili, or the human HPV test is positive, you are going to advise that mother to go for colposcopy. And in some places, VI-Vili, there's the screen and treat. So you saw those white or yellow lesions. Some people are able to offer cryotherapy, or now there's thermal ablation. So I forgot to add it on this one, to treat those lesions. So the treatment for precancerous lesions is cryotherapy. So that is freezing. Like, remember the white lesions we saw? We're going to put a special probe that's going to cover those lesions, and we're going to freeze them. And that will stop the changes from progressing. We can also do thermal ablation. So it's done in a similar manner. You put a probe that's going to hit the tissues and stop them from undergoing those precancerous changes. With a LEEP or LETS, so LEEP is loop electro excision procedure, or LETS is a large loop electro excision of the transformation zone, whereby those white or yellow parts, we are going to actually surgically remove them until the margins are clear. In some cases, you're going to do what is called, the old treatment was a cold knife cone biopsy, and it's going to remove the abnormal parts of the tissue. And when you send this to the pathologist, a treatment would be considered if the margins are clear and do not have any signs of cancer or precancerous lesions. But because we're talking about precancerous lesions, it'll be for the precancerous lesions. Now, if our treatment, our prevention doesn't work, we're going to get overt cancer. And I think Sheila mentioned that you have stage 1, 2, 3, and 4 of the cancer. So specifically for cancer of the cervix, stage 1 is limited to the cervix itself. In stage 2, you have the cancer cells spread outside of the cervix and into the vagina. So into the upper 2/3 of the vagina and around the uterus. In stage 3, they go all the way to the lower part of the vagina, or all the way to the walls of the pelvis. And it has, I think in stage 2 and 3, it also, the lymph nodes can be affected. In stage 4, so the time when you have, what do you call it? Spread outside of the pelvis, we now call that metastasis. And you have the near metastasis, that's the bladder and the rectum. Those are the organs that surround the uterus. And distant will be things like mets to the liver and the lungs. So this is just, again, a diagram. So in stage 1, the cancer is limited to the cervix. In stage 2, it has gone to the vagina or out to the body of the uterus, or just outside the uterus. In stage 3, it's going all the way down to the lower 1/3 of the vagina, and it's reaching the wall of the pelvis. And in stage 4, you can see the rectum or the bladder is also affected. Treatment is based on the stage. So in very, very early, we can afford to just remove the cervix only. And this is very important in somebody who wants to still maintain childbearing. So they have desire for future fertility. But the moment I think that would be for people with 1A, so the very, very early disease. But up to stage 2A, we are going to remove what's called a radical hysterectomy. So we're going to remove the uterus, the upper part of the vagina, and lymph nodes. We don't have to remove the ovaries, but depending on the age and the desire, depending on the age, we may remove the ovaries or not. If you are not going to remove the ovaries, we have to suspend the ovaries away from the pelvis to enable radiation to take place. For the radiation, we are now combining it with chemotherapy. This makes the radiation works better. We're in the era of what we call multidisciplinary approach to care. And because you find other systems can be affected, you're going to have consultations with the hematologist. I see Irene's hand is up. Or do I just finish and ask? Maybe I just finished because I think I'm almost through. If you can just put questions in the chat. And now that Irene doesn't want to speak. Sasa. So we can consult a hematologist. So that's somebody who's concerned. He's a doctor that primarily works with disorders of the blood. The renal physician are kidney specialists. The interventional radiologists. So you find, like, for example, in cancer of the cervix, a lot of the time, the ureters are blocked. So the ureter is the pipe that takes urine from the kidneys to the bladder. So they are going to get kidney failure because of that. And in some cases, we need to drain the urine from outside. So that's what the interventional radiologist is going to do. We're going to have also consult with radiologists for staging. And also we have what we call the radio-oncologists who are going to set you with radiotherapy. We have the medical oncologists who are going to assist with chemotherapy. Nutrition is obviously a very, very important part of the treatment, because if the tissues do not have adequate oxidation and nutrition, they're not going to respond well to treatment. And very, very important part of the team is the palliative care team, who are going to include both counselors and pain management. And as I've said, it's going to be a multidisciplinary team that's going to manage the patient. So there's some quick facts. I think from this chart, they said it's the second, but I think it's the fourth most cancer affecting women. It's caused by the human papilloma virus. And we have about 600 cases every year. The symptoms of the abdominal vaginal discharge or bleeding in between periods or after intercourse, pelvic pain, and risk factors include smoking, multiple sexual partners, being overweight, and a history of cervical cancer. From our resources, obviously from FIGO, World Health Organization, Ministry of Health, CDC, WebMD, and Wikipedia. And I'd like to thank you and ask if you have any questions at this time.
Sign up as you take over. I note there are a number of people with hands up. So Zainab, are you there?
I'm there, Daktari. I can hear you. Are you able to see the questions?
Yes, I'm able to see the questions.
Mm-hmm. Maybe you can pick them.
Okay, so I think we have, okay, everybody's anonymous, but that's fine. I don't have an issue. So
Yeah.
do vajacials, oh goodness, increase the chances of getting HPV? I'll have to Google what vajacials are. I don't know, does anyone know what vajacials are? Zainab, you're the Nini?
I was also wondering, maybe it's a misspelling or something. I'm not so sure.
Daktari, actually, apparently it's a facial for the yes,
I forgot.
a
Yes.
vajacial.
Vajacial. Oh, yay. Hey, kuna watu kuna maswag kweli kweli. Okay, yes, I'm actually aware about vajacials, probably not thinking. We have said that if you're going to share items, so I think previously, like I'm someone who okay, sorry to mention, but our preferred method of removal of hair in that region is waxing. So when I was much younger, we didn't have the disposable strips to do that. So they were reusing those strips. So what we do know is, and I feel for those who are doing vajacials, is that probably the spelling is also not going to be vagina. Anyway, maybe it's spelled like that, I don't know. Would be if they're using disposable items and they're gloving, I would say no. But obviously, if they're reusing any of those items, then the answer would be yes. So it's anything that is giving you either close proximity to somebody who is infected or reusing somebody who is infected, their items. Then our back pains after CS and heavy periods after birth, a red flag for cancer. I would talk about, say, back pain. Back pain after pregnancy is, pregnancy itself is actually quite common. It's not necessarily the CS. And the reason for this is during pregnancy, you find your center of gravity has moved. So you, in order to stay upright, it's like you kind of instinctively stand in a different way. So it really causes that lower back pain. And for the lower back pain, I think it's just seeing either your doctor or a physio, and they can advise you on exercises to do for the lower back. Obviously, see a doctor first, because it's always good to rule out some serious things. You know, you can start doing this and could have a prolapsed disc. So just see a doctor so that they can and you do the exercises, and that should help. Heavy periods, if it is immediately after birth, if it's something that persists, it would be a red flag for cancer. But a majority of cancers, the red flag is bleeding outside of the periods or any discharge outside of the periods. So I hope I've answered that. Is diet and regular exercise a good preventative measure for cancer? If so, what food and what exercises? So I think you can see from my risk factors, we didn't mention anything. However, for a healthy lifestyle, we do always propose a balanced diet that has everything from all your food groups, your proteins, your fats, and your starch, and not forgetting your fruit and veg, and don't forget a lot of water. Being healthy would improve your immunity. And remember, we don't know why some people, either they have very good immunity or other have very low immunity, will develop cervical cancer, and others don't, and would have similar risk factors. How affordable is a pap smear? A pap smear would range to anything. I think in our hospital at Kenyatta, we charge about 1,000 bob, and I don't see anybody charging more than 5,000. If there is, it's possible, but definitely not more than 6,000 shillings. So it just depends on which healthcare provider you're seeing. At my private clinic, I personally charge 3,000 bob for a pap smear at present time. Let me see if there are more questions.
Dr. as you check
Maybe
through
just before you pick the next question, I'm seeing 2 hands raised. I don't know whether you can hear me.
Yes, I can hear you, but I don't know if who are the people whose hands are raised?
Let me just put them on. I see if you are able to, they are able to, let me unmute them. I see if they are able to talk. I have Roslyn. Let me just unmute her. Okay, can you talk now, Roslyn?
Yeah, good morning.
Good morning to you.
Good morning,
Karibu sana.
Roslyn.
Yeah, hi. I'm from Eldoret. So my question is, should a child not have begun to engage to sex that to have the vaccine of that age of between 10 to 14 years? Because I had I wanted to have someone to have the vaccine, but I was told you have to confirm from the child that she must have not engaged from the sex. So I was confused on that. So kindly tell me about this.
Okay, I think for whoever is giving the vaccine, those I think barriers. Remember, we have said even women 30 to 45 can still benefit from the vaccine. And the younger you are, the more the benefit from the vaccine. They will definitely benefit more if they have not had sexual activity. From the research we found, it's that those who are naive can benefit from just 1 or 2 doses of the vaccine. But for those who have undergone sexual activity, maybe they need the full schedule, they need to get the 3 because the full schedule is 3 vaccines. Our schedule is 2. I feel it's not relevant. And what's the likelihood that a 10 or 14-year-old, I know some have undergone sexual activity. The likelihood is very, very low, which is why that age was considered. So please just have them go for the vaccine. Even if they have had sexual activity, it's definitely going to be benefit to that person.
Okay, thank you. Thank you.
You're welcome.
I can see Zipporah Wanjiro. Zipporah, maybe let me unmute you. Let me see if you can come on. I don't know if you're still around. 1 minute. Zipporah, can you come on now? Not yet.
I think she's still muted, Zainab.
Okay, 1 minute.
Hello.
Okay, from our side, yes.
Hello.
Okay, Kenneth, are you on?
Yes, thank you very much.
Karibu.
And yes, and I want to appreciate Dr. for the good presentation. And as an advocate, I just wanted to highlight just a few points on screening component. So I know the WHO recommend that we use HPV as a gold standard for screening. But now look at our protocol. We start with the VIA, which is normally subjective and individual interpretation based on what somebody sees. So I don't know whether as a country, we should now start talking about pap smear as a standard goal for screening as opposed to going to VIA. So we are also talking about the pap smear as a method of screening for cervical cancer, but how available is this for the population? I know for VIA, there is no cost for that. For pap smear, we have to pay for this, which will not cover the entire population in terms of doing screening. Then for the vaccines we are using in the country, I know it covers majority type 16 and type 18 HPV virus. But I know this is from the assumption that this is the most common HPV we have around. But I know there have been some studies looking at the other types of HPV high risk apart from type 16, type 18. And we found that we even have more high risk HPV, the oncogenic ones, apart from 16, 18. And how is this going to advise us in terms of what kind of vaccine we need for the country? So thank you very much.
Can you hear me?
Yes, we can hear you, Dr.
Okay, thank you, Kennedy. You've raised very interesting questions. What I'd like to assure you is even the PAP is not like 100%. And you find a lot of research has been done in terms of the efficacy of all these methods of picking up precancerous lesions. And you find that for both VIA and pap smear, it's about 75%. So you should not get concerned whether a VIA Vili is being used or a pap smear is being used. I personally still prefer the pap smear because there is something that is reproducible. And if in doubt, you can always take that slide to somebody else to do. But we are cognizant of the fact that not everybody is going to afford the pap smear. And VIA Vili is actually a very good, alternative to the pap smear. The HPV testing, I think, is the most expensive because to the best of my knowledge, I think a kit is about 5,000 or 6,000 and probably higher now because I think we all know the way dollar has gone up. If the prices have gone up, it's going to go up in the near future. So don't really stress yourself that, oh, I'm getting a VIA Vili, it's inferior to the pap smear. That would not be true. The more important thing is that I'm getting screening, I'm taking control of my health, and I'm looking after myself. So I really encourage people that if you're doing a VIA Vili, it's not necessarily inferior to the pap smear. So I think I'm still in support of the government and the rollout of the VIA Vili. We have gotten in Kenyatta a lot of referral from surrounding from surrounding places for colposcopy. There's what we call the see and treat where they are giving the ablative therapy. But remember, even if you have undergone the therapy, you're still going to have to go follow up and screening. So if they have that somebody has undergone therapy and they're still having a persistent lesion, these patients will be referred to higher centers of care. I think that was the last question. You can just repeat the last question, Kennedy. I'm sorry.
Yeah, the last question was about the vaccination. We give the vaccine that covers type 16 and 18, and maybe from assumption that this may be the most oncogenic type of HPVs we have in Africa, including our country, Kenya. But I know some studies have shown that apart from type 16 and type 18 HPV virus, we have other non-16, 18 HPV. I mean the high risk ones as opposed to 16, 18. So if this is the case, for those who we are giving vaccine to target type 16 and 18, and maybe they have non-16, 18 high risk ones. So is the vaccine really going to cover the entire population on an assumption?
Okay, so I think, thank you very much, Kennedy. I'll go back to the research that I showed you from Scotland, and it's understanding that these other non-16 and 18 would be available worldwide. And from their data, just by giving the type 16 and 18, because with the bivalent vaccine only has against type 16 and type 18, and they had no cases of cervical cancer in their population that was vaccinated. So it's also remembering that you may be vaccinating against type 16 and 18, but you get some cross protection for other types. So probably that could explain why there's that possibility. And it's remembering from stats, more than 75% to 80% of cervical cancer cases will be because of type 16 and 18. So from a population-based perspective, you're actually doing a lot of good work by vaccinating against type 16 and type 18. The other issue now, if you also look at from a cost perspective, if I know the cost in private sector, so you find like the bivalent vaccine is, I think the cheapest you get right now is about 5,000 or 6,000. The nonavalent, which is against 9 strains, is about 45 to 60K. Now, it's just too expensive to give the nonavalent. So the nonavalent would be against 9 strains. I'm sure about 16, 18, 11, 6 and 11. I think those were against 35, 26 and some others. But it's also too expensive to imagine vaccinating everybody with something that costs 50,000. It's also not feasible. So when you're doing public health, you look at the intervention. I think they follow that Pareto principle, whereby you take that one thing that's going to have a very high impact. And for me, from that Scottish study, the bivalent vaccine is very good, and I would still advocate for vaccinating the population bivalent. At such point that the monovalent vaccine becomes a similar cost to the bivalent vaccine, then at that point it would make sense to now shift to using the monovalent vaccine. But until that happens, it's also not practical, because unfortunately in healthcare, cervical cancer is not the only cancer. And in public health, you have to look at the entire population. You have to think about other cancers, breast cancer. You need monies and treatment for all these activities. So for me, it's an intervention that has been proven to work, and the stats are impressive. I would not stress myself so much about it.
Thank you, Dr. And lastly, just last question about the end results of vaccination. So if a young girl is vaccinated today, I know the vaccine will protect the young girl from getting the effects of HPV virus. But now, will this population still be able to transmit the virus in terms of contamination as opposed to infection by the virus?
Okay, that's one I'll be very honest. I would have to check, but we do know that even just by vaccinating boys, you're protecting the girls, and vice versa. So for me, it would be possible that somebody, because of the close proximity, so let's say, for example, you have someone who has multiple sexual partners, or we have told you that the human papillomavirus is something that spreads very easily. So I'm vaccinated, I have intercourse with someone who has a human papillomavirus, and go and have intercourse with somebody who does not have the virus. There is that potential that I'm able to spread to them without necessarily now getting the effects. For me, I will get the virus, but because I'm vaccinated, my body will not suffer the effects of getting the virus because of the immunization. But the person who does not have is not vaccinated may now get the effects of the human papillomavirus.
Thank you, Dr. Maybe I'll request you maybe to drop off your presentation, because somebody is asking on the rates of femina, so that we can put it up for our viewers.
Okay.
Meanwhile, there's a question here. It is intentional that the vaccine campaign seem only to target young girls and boys. Even in your slide, it is specific on certain age group. Later on in the slide, it is mentioned that the vaccine can be given up to 45 years. The narrative for older women seems to be a regular pap smear. Why isn't it that the narrative should be all women should get vaccinated? I think by the end of the question is why all women should not get vaccinated.
As we've said, in public health, you look at the interventions that you're going to yield the most benefit. And it's remembering whether vaccinated or not, you still have to undergo screening. So having undergone screening, vaccination does not exempt you from going screening. So that, please, let's remember that. Why we have not saying all women should get vaccinated, I think with time, that will be the what do you call it, the norm. And for me, let us concentrate on those who will benefit the most, and those are people who are sexually naive, i.e. have not yet been exposed to sex. Let's ensure all our young girls are vaccinated. If every year, just assume all 10-year-olds were vaccinated, you find that in the next 20, 30, 40 years, we'd have more than 80% of the population has actually been vaccinated. So it's an issue of cost, it's an issue of that, but we are in policy, we are in advocacy. Those are some of the things that we can advocate for, because I find it very, very sad that right now, because we're unable to convince parents to have their young girls vaccinated, then can we vaccinate those who are willing to get vaccinated? And it's easier to convince adult women to vaccinate than have their young children vaccinated. So as you're doing that, what does it mean to be HPV 16 negative and 18 positive? Long and short, you are positive for a high risk HPV. Remember, we have said there are several strains, and you're normally infected by one strain. We normally test for both 16 and 18 because these are the most oncogenic, they're the ones that cause the most cases of cancer. So being positive with one of these is a sign that you need further testing. We normally are going to send you for a colposcopy, and based on the colposcopy, a decision will be made on what the next point of treatment. Which hospitals offer the HPV vaccines? I think because it's available even in public hospitals, most private hospitals do offer it. I'll share my contact once the Femina thing is over. For Ready Searchlight, you have mentioned, you think are working on a request. Sorry. You don't need to test for HPV to be in order to be vaccinated, but it just means it's just good that you get a screening while you're getting the vaccination. After one, one should get tested for the cancer if they have already been tested. So it's understanding the test we do is a screen, and we're screening for pre-cancerous lesions. That means the changes you get before you actually get cancer. So for the vaccine schedule, we did mention at least once every 3 years. That's the current recommendation. If you want to do it more frequently, that is okay, but the minimum should be once every 3 years. If you have found that you went for a test and we found you have cancer, then it means immediately you need to start treatment. We can't wait. Is there a correlation between cysts, fibroids, endometriosis, severe dysmenorrhea with cervical cancer? So this is somebody who seems to have a lot of issues. You find that we don't know what causes fibroids, endometriosis, and severe dysmenorrhea is the painful periods. Patients with fibroids and especially endometriosis can have painful periods. So endometriosis is one of the key symptoms for endometriosis is very severe cramps, and that is what we call severe dysmenorrhea. If there's any correlation to cervical cancer, I would say the answer is no, because cervical cancer, there's a higher correlation with sexual activity. Are there any side effects of the vaccine? I don't think there's anything in life that does not have side effects, but most of the side effects are local irritation at the local site of injection. We've had some very few cases of severe side effects, so it's not worth it to stop the vaccination. Very, very few. Most people have the vaccine and they don't have any side effects. So I think for men, how else can they protect? So you can still protect the boys, as you rightly put, but condom use and male circumcision. And please, let's stick to one sexual partner. And I think in that way, we can really reduce that. So I think we'll stop at that question so that we can go to the Femina presentation. Then I can come back to the questions again. But I think there are only two. Do I just finish the two?
Yeah, Dr. You can proceed. We had already done the webinar presentation. Somebody just wanted to see the slide.
Okay,
but just before you pick the next question, there's somebody who has asked here about future births. Dr. What exactly do you mean by removing a cervix? And is there a replacement? Then two, if a lady has cervical cancer on intercourse, what does this mean to a man in terms of infection? Three, can you be pregnant if your cervix has been removed?
Yeah. So I think the number 1 and 2 are similar questions. So I don't know if I can share. We go to the anatomy of the cervix. Thank you.
It's okay. You can share.
Just so it was right at the beginning. So here we are. So I don't know. Can you see my cursor?
Yeah, we can.
Okay. So if you see where the cursor is, so this is the uterus, the entire uterus. So this is the body of the uterus, and this part is what we call the cervix. So if somebody has early cancer, we're only going to remove the cervix. But you can see there's still a pathway into the uterus. We're not going to remove that. So it means that the person can still be pregnant and still carry the pregnancy. It's just obvious that without a cervix, they have higher risk of preterm birth and higher risk of operative delivery. So yes, you can still have, if the cervix has been removed, you can still carry a pregnancy. They most probably may need to have a stitch, but these are all decisions made by the oncologist. We have special doctors who specialize in gynae oncology. We call them gynecologist, and they're going to make that decision whether they're going to remove the cervix only or remove, but majority of operations for cancer of the cervix, we're going to remove the tubes, the uterus, the cervix, and lymph nodes and upper part of the vagina. All that is going to go in the normal surgery for cancer of the cervix.
Okay,
there was some middle question about man and cancer of the cervix. So the issue, I don't think, the issue is the human papilloma virus, and someone with cancer of the cervix, it would go without saying, should be infected with human papilloma virus, one of the oncogenic strains. What we do know that the men can also get the human papilloma virus, and it can be responsible for penile cancer, but it's not as common as cancer of the cervix. So it really has detrimental effects to the partner. Obviously, if she has overt cancer, she's bleeding after intercourse. I mean, it's the discomfort, and it's not very pleasant that your partner is bleeding during or after intercourse, obviously. So, but you find for the man, they're not that affected. Where's the Q&A? So back to the questions is, Hi, had 2 pap smear screenings. One says HCIL recommends colposcopy and biopsy, and the follow one says ask us recommends a pap smear in 6 months. What would your advice be? For me, I'm a clinician. Clinicians, we have what is called high index of suspicion. I don't know why someone would repeat a pap smear when you have a HCIL. The moment you have a HCIL means a high-grade squamous intraepithelial lesion. This is direct, you should go for a colposcopy. And so that would just be the recommendation. It's not to repeat the pap smear. A HCIL, direct, go for a colposcopy. So I would stick with the first recommendation. Then can one get HPV treatment while pregnant? What I do know is we are able to screen while pregnant, but the treatment would be cryotherapy, it would be ablative surgery, most thermal ablation, or the LETs. Most of the time, most nations will defer treatment up to when the pregnancy has resolved. So, and I think with that, we have dealt with the questions in the Q&A section. And it's exactly 9:30.
Thank you so much, Daktari. Please share your location as you tell us where we can find you.
So, dang it. So I'm at 40 Suits. That is at next to Kenyatta National Hospital on Hospital Road. We're on the 7th floor at a clinic called Gynacare. I was trying to get an image, but I don't have to do a slide share. Let me just see if I can do this. 1 minute. It's not coming up. Sorry, the image is not coming. I don't know if it's my network that has gone.
Maybe you can just tell us the location, and also we'll be sharing with our viewers.
So I have this, so can share the screen. Oh, I'm not seeing that particular one. It's not coming. Sorry, it's not coming what I wanted to come. So sorry about that. Let me try this. No, it's not the one. I'll just stop the share, it's fine. So, but we're at Gynacare, and that's where our clinic is.
Ms. Zainab, maybe we can share on the chat that her contact or.
Yes. So, and the clinic number is 0768. But I can do that. I can do it on the chat. Sorry, thanks.
Thank you, Daktari. I think we have quite a number of questions, but unfortunately, Daktari's time is up and she has to be somewhere else. So I want to take this opportunity to hand it over to our head of case management, Madam Jemima Mbugwa, maybe to say a vote of thanks. Over to you, Madam Jemima.
So thank you very much to the team. Special thanks to Dr. Maureen Owiti. We really want to appreciate you because of your time. 1.5 hours of a doctor's time is quite expensive, and we don't take it for granted. Daktari, asante sana for a very educative session. I believe all our gentlemen and all our ladies who are logged in this morning have learned something. We are going to be sharing this presentation. You can also follow us on our social media. It's going to be put up there. It's also going to be on our website. So do not hesitate to access and maybe refresh I also want to give special thanks to our Chief of Staff, Irene Mutonyi, who has really taken us through the Women Program, a very exciting product that we have as APA Insurance. And as we asked, if you would want to get to know more about this and Femina Plus, please feel free to contact us on the contacts that are going to be on our chat, and we have been projecting them over. We can also reach you all out if you would be interested. Again, we can call you. We have a business team that is involved in reaching out to customers, and we can offer you these solutions that are now in the market, that we have brought into the market. Back here on studio, I want to thank Zainab Okalo, who has been hosting us and taking us through. Thank you so much because of being on time and just help moderating the session. We also have Justus Munene on my left, and he has also been helping us with the questions and also just coordinating the technology around here. And in the room, we also have Deborah Naliaka. Thank you so much because of making this a success. We always have webinars once every month. So please watch out for the next one at end of February so that we can continue to live and to learn. Asanteni sana. My name is Jemima Mbogwa. We are here to ensure that we have a healthy population to thrive, and not just to survive, but to thrive, healthy people. So with that, we want to say adios, asante sana, and God bless you all.